a very important issue, but we have to move on now. And is Rohit here?
In the topic,
Right.
decision and black cataracts.
Oh, wonderful. That's even better. Thank you.
Am I audible, sir? And is my screen
Yes,
visible?
yes. You're fine.
Yeah, I would like to thank Dr. Namrata for the opportunity. And I would be dwelling on a topic which is very dear to Dr. Abhay, our panelist. So I would be talking about...
There is Rohit, there's a small box, black box, which is coming on the right side. So can you unshare and share again?
Yeah, stop sharing. Exit. Just give me a second. Is it okay now?
No, still coming. Okay, we will. It's a black box in the black cataract, so that will be fine.
I hope it's not in the. It's not.
No,
in
it's
the
not in the side. It's in the side. It's not there in the.
That's okay, Rohit. You go ahead. Don't worry about the.
Yeah,
Build order, no build effects. It says build order. I don't know.
I think you need to switch off the transition effects.
Yeah, I think I'll do that.
Transitions.
How do I do it?
As I said,
Sorry.
we can't wait now to listen to your pulse. So go ahead.
Yeah. So decisions in black cataract I was supposed to talk about. So, these black cataracts are very challenging because the morphology is different. The visualization is poor. Emulsification is difficult because the separation at times at the end is also very difficult. The production of energy is excessive. Chamber stability, high incidence of PCR, corneal endothelial insult, more than in any other case. Zonulopathy associated, small pupil are some of the things which are associated with black cataracts. So the next point is the incisions, which is a very small thing, but it needs to be looked into because the main incision has to be appropriately sized too, with no leakage and over tightness. Over tightness can give corneal burn. The side port incision has also to be calibrated because excessive leakage through that can also cause, unbalanced or unstable anterior chamber. Capsulorhexis challenges include visualization of the anterior capsule is very difficult at times. We have to do staining by all means for visualization and for being sure that while doing the chopping, while moving the pointed chopper, there may not be any anterior capsular tear. Rhexis sizing is also very important. Small rhexis has its own problems because it causes manipulations of thick nucleus, making it predisposed to zonular stress. Large rhexis predisposes to endothelial trauma. So we have to plan an appropriately sized 5.25 to 5.5 millimeter rhexis. Hydrodissection, we have to be wary of the fact that there is an increased anterior-posterior diameter of nucleus. There is less space for fluid to go in, and the posterior capsule is thinned out. So the next point is, so what do we do in hydrodissection? If I cannot see the posterior capsule, I rarely hydrodissect. If you have to squirt tiny aliquots, do gentle decompression, and do it in multiple quadrants, this hydrodissection with tiny aliquots. Choice of phaco choppers is also very important. Pointed chopper and blunt chopper, using it differently, which I'll be showing in the videos. So this is a black cataract, wherein you will find that I'm going to do direct chopping in this patient. So here you would see what I have done is I have bared the phaco tip more from the proximal end, and I'm going to go direct deep into the core. Once it is firmly held, then the chopping can be adequately and clearly done. That is the thing which is most important. At times, you will see in this, if there is inadequate holding, as you would find now, it is not fully deep. I'm trying to chop it. There is an instability. So I go in again and then I chop it. So total good holding is very important in these cataracts. This is the rubra one, in which the anterior posterior diameter is less. So I'll create a small central crater. Anterior chamber depth was also less. Once that was done, then you go fully deep in, chop it. Since I was adequately deep and it was firmly head, I could chop it. Now in this patient, the anterior posterior diameter was less and I was suspecting some bit of weak zonulopathy. So I did cross chopping to create a space. Cross chopping was done. This small nuclear fragment was separated and then I just emulsified it. Next is multiple level chopping, as has been shown by Dr. Abhay. See how I am moving this chopper. See again, I'm holding it firmly, chopping it, single chop, going deeper. Then I'll go more deep so that I separate it fully. So this is the click, which now I'm changing the chopper because I have already chopped it into partially into different nuclear fragments, going in and doing in multi-level chopping. So multi-level chopping is another thing which has to be taken into consideration. Leathery posterior plate is another important factor which we have to see because it is very difficult to take it out. So what are the different ways? Use long chopper, deep sculpting, multi-level separation, bimanual technique with Sinskey hooks with the bag adequately inflated, and the rest I will show in the video. So here what I'm doing is I am doing vertical separation. You see I'm bringing the one fragment forward and pushing the second back. That is the first type. The second is holding the stalk. And once you come close to the stalk, you hold it. And once you hold it, and then you separate it and you will be able to separate it. The third type is, what you do is you emulsify the stalk at times. You see, I'm emulsifying the stalk. See how again I'm emulsifying the stalk. So these are the different things which need to be done. Next is black cataracts with flax. You will see in this, what is happening is capsule rhexis is being done, has already been done. So it's being taken out. So with the softening and partial fragmentation, it becomes very easy to use flax and create definite separated nuclear fragments. So next is strategies how do we have pristine clear corneas? So you should do deeper plane phacoemulsification, total separation of nuclear fragments, create small nuclear fragments, then totally separate them, recoating of corneal endothelium with a viscodispersive and use a chopper shield. Now, what is this? Now, what is this chopper shield? In this, you will see how strategically the chopper is being placed between the endothelium and the nuclear fragment, which is being emulsified. This brings down the insult to the corneal endothelium by all means. So what are the predisposing factors for PCR? Smaller rhexis, peripheral extension of rhexis, squirting sudden large amount of fluid for hydrodissection, tightening of the eye with fluid trapped while doing hydrodissection and trying to decompress, rotating using forces with two-handed technique, pushing while sculpting, unsuccessful continuous separating forces at the same tip, not multi-level, pulling rigid large nuclear pieces after unsuccessful chopping, pointed nuclear piece hitting the posterior capsule while doing IA, and unstable chamber settings, and while emulsifying the last nuclear fragment. That is also very important. So these are the key points: definite groundwork of incision, rhexis, hydrodissection, choppers, and phacotips, balanced phacotips, which was being used in these cases, total division, separation, chopping whole nucleus into smaller pieces, separation at different planes, different places, and different directions. And these are all. Thank you very much for your kind attention.
Rohit, we recognize you all.